Hello everyone, welcome back to my channel. And the topic for today is liver cirrhosis. Now, this clinical condition is on rise, and frequently in our clinical practice, we see patients coming with ultrasounds showing liver cirrhosis. So, just walk through as to what it is and what are the things that we must remember when we are dealing with case of liver cirrhosis. So first of all, let us see what is the definition. Now this is a irreversible diffuse fibrosis in liver plus association of regenerating nodules. Now, just to understand the pathology, let us see what is the structure of normal hepatocyte, the liver cell. So, in this normal structure, there is a central venule. Okay. There are blood vessels. There are sinusoids, and of course there are all hepatocytes, and then there is a portal triad which consists of an artery, vein and bile duct. Okay, so what happens is that from the hepatic artery and the portal vein, the blood goes to central venule, and from this central venule the bile comes out and goes into the bile duct. So this is the whole physiology. Now what happens in the pathological state? The regenerating nodules which form, they have no portal triad, which is very important. So there is absent portal triad, and there are no sinusoids. So what happens as a result of this? There is raised sinusoidal pressure and there is raised hydrostatic pressure. So that is what happens in the case of liver cirrhosis. Now let us talk about what are the causes of liver cirrhosis. Now the most common cause is, of course, patient who have been taking alcohol for long. Number 2 is post-necrotic liver cirrhosis. Usually after hepatitis B and C, this can be seen. Then in certain autoimmune disorders like primary biliary cirrhosis or autoimmune hepatitis, this can be the end result. And then metabolic disorders like hemochromatosis or Wilson's disease or alpha-1 antitrypsin deficiency, galactosemia, again primary sclerosing cholangitis. So these are the conditions in which this can happen. Now for the diagnosis, if you really want to confirm it, then you have to go for liver biopsy, except if in case you are suspecting primary sclerosing cholangitis, then liver biopsy is ruled out. Now what are the symptoms of liver cirrhosis? Of course, icterus or jaundice, then pallor, then bilateral parotid enlargement. Often in geriatric cases, this can be an indicator. Then cyanosis, spider nevi, palmar erythema. In general physical examination, this you can find. Then Dupuytren contracture, flapping tremor, ascites, splenomegaly, caput medusa, and gynecomastia, or patient can also have testicular atrophy. And then of course alopecia, loss of hair. So these are the signs and symptoms that we will see in cases of liver cirrhosis. Now let's talk of the complications that we must be aware of. Number one, most important, portal hypertension. Okay, so in this case, patient will have ascites, splenomegaly, upper GI bleeding can happen, varices, gastropathy. So you have to take this into consideration. Of course, splenomegaly is something that can be there. Sometimes it is massive. So it can come up to umbilicus, hypersplenism, which causes pancytopenia. So patient can be really in a drastic state. And then when we see ascites, what do we understand? So this is a collection of fluid in the peritoneal cavity. Now if it is really massive, then we can definitely detect by shifting dullness on examination. But if it is minimal, then you can definitely advise ultrasound abdomen. Now what happens is that whenever liver is affected, liver is responsible for producing protein albumin. When this is less, as a result of this, there will be less oncotic pressure, which raises the hydrostatic pressure, which is why there is fluid leak out of the vessels. That is why ascites is happening. Now usually tapping of the fluid is advised, which is also called as paracentesis. In the first visit, sometimes tapping is done, and in the second visit, if the patient has fever, abdominal tenderness, then aspiration is done, because of a bacterial peritonitis. Now if there is a known case of ascites, but the patient develops fever along with rebound tenderness, then chances are that they have had spontaneous bacterial pyelitis. So it is advised that we can advise the patient for ascitic fluid culture. Okay, so these are the investigations. And then you can also in this find gram staining of ascitic fluid. Okay, so you can also go for culture. Now the best test is, it should have more than 250 neutrophils in every ml per ml of ascitic fluid. That is diagnostic. In that case, the mortality can be more than 70%. Now, I also mentioned the term varices. What do you understand by that? So these are portal anastomosis because of they actually cause upper GI bleed. Okay, and the patient may present with or may come with a complaint of hematemesis, so vomiting of blood. Whenever this situation comes, we can also think of other diagnoses, like most common one is peptic ulcer disease. You can also think of patient with gastritis, they might have it, and of course CA stomach, and then Mallory Wilson syndrome. Now, whenever hematemesis patient comes, it's very important to assess the severity of hematemesis. Okay, so you should see symptoms like hypovolemic shock. What is that stage? The patient will have tachycardia, tachypnea, dyspnea, cold peripheries, and may even have altered sensorium. So whenever such situation happens, first thing to do is check pulse, BP, and orthostatic blood pressure should also be checked, that is from supine to standing position. Okay, if the heart rate is more than 10 per minute and the systolic blood pressure lowers by more than 20 mmHg, that means amount of blood loss is 10 to 20%. So in this way, we must assess the severity of hematemesis. If it is more than 20%, 20 or 40%, then it is moderate. If it is more than 40% loss, then it is severe. Now, how to approach this case? First, if varices come, you have to stabilize the patient hemodynamically. So you have to bring the systolic blood pressure to 90 mmHg. Otherwise, there will be hypoperfusion of vital organs and it can really cause MI, and the patient can have acute renal failure because of oliguria. Okay, then we must send a blood sample for CBC, prothrombin time, cross match. You should advise for quick ECG. In 80% of the cases, bleeding usually stops whenever they are given IV fluid, and again, endoscopy is something that is advised. Blood transfusion is given. It is required in cases. Sometimes packed cell is given. Platelet transfusion, and for coagulopathy, fresh frozen plasma is advised. Now, whenever we talk of homeopathic approach, we need to remember, and we need to also make sure that we are giving this awareness to patient that this is irreversible, because the pathology is irreversible. What we can do as homeopathists, we can look after cause and the complications. So again, based on the individual presentation and how the analysis is presenting, and considering the totality of the case, you must advise the remedies. But just to give the list of remedies that are wonderful in these cases, you can think of Cardus marinus, you can think of Nux vomica, Lycopodium, Chelidonium, Phosphorus, or a mure, Feltori, Kaliiode, Quassia, and Podophyllum. Of course, there are many other remedies, but these are some of the common remedies. Sometimes organopathically they are prescribed, and sometimes on the basis of totality they are prescribed in usually lower potencies and repeated doses. I hope this information is useful, and please share it with all the homeopaths and all the doctors in order to just brush up and walk through this once again. Thank you so much for watching.